Thank you so much for reminding. So yeah, Reena, you were sharing your thoughts about the word patient's expectations. Go ahead, please.
So almost all the points have been discussed, but what I was thinking is like patients also expect value for money. Like
Mhm.
there are instances where in our hospital they pay for a private room, okay,
Mm,
but
mm.
in the private room the TV is
Thank
not.
you for reminding, and I would request always to remind me because I can forget. I'm so sorry. Thank you so much for reminding. So yeah, Reena, you were sharing your thoughts about the word patient's expectations. Go ahead, please.
So almost all the points have been discussed, but what I was thinking is like patients also expect value for money. Like there are instances where in our hospital they pay for a private room, okay, but in the private room the TV is
Thank
not.
you for reminding, and I would request always to remind me because I can forget. I'm so sorry. Thank you so much for reminding. So yeah, you were sharing your thoughts about the word patient's expectations. Go ahead, please.
So almost all the points have been discussed, but what I was thinking. It's good to go.
Extremely sorry. I think the audio was getting repeated because of the YouTube, so I've closed that. Yeah, we are good to go.
Okay. So yeah, I mean, various facilities which the hospital has to offer. Like if you pay this much, you get a private room. In the private room, you have these facilities. So the person is okay. Wow, I'm gonna be fine over there. I have this for entertainment and all. And when they don't get it, they
Mm.
ultimately say during discharge, "Why is so much charges? What's the use? I paid this. I didn't get this. I didn't get this." So I mean, these are the kind of expectations which can't be ignored.
They are disappointed. They're
Yes.
disappointed. Yeah, I completely. So anybody has any different idea about patient expectation, Captain Sandhya?
Hello.
Yeah,
Hello.
please. Yes, yes, go
No,
ahead.
it's completely covered because this is what Reena just said. While listening to everybody, I was going to say it's value for money, and
Money value.
that comes first actually
Yeah.
nowadays when we interact with patients. Surgery, be it the course of treatment, be it the room, be it the hospitality, services in
Mm.
the hospital, starting from their entry, security, front office till their exit, discharge, and billing. Everything they want value for money actually.
Completely
So
agree. I completely agree with you. So that means somewhere we have to do. So do we value it? Do our
can I, sorry, one thing.
please go ahead, ma'am. Yeah, yeah.
And in addition to value for money, one thing which is surfacing, and it is surfacing now, probably we, the healthcare workers, are responsible for it.
Mm.
The point which is surfacing frequently is empathy and human touch. Patients have
Mm.
started to feel lonely being in the
Mm.
hospital. They've started to feel lonely a lot. And I'm saying sorry, I remember because today I dealt with such a similar experience. It
Mm.
actually touched me deep. And
Mm.
but this is a frequent phenomena, be it as young, as vibrant, a celebrity, a VIP, or any age group, any cadre, any category. But because probably we are responsible for this.
Yeah,
I
Dr. Radha, I'm coming to you.
yeah,
Just
all
give me
right.
1 second. So I
Yes.
completely agree with the Captain Sandhya. Although now, in terms of facilities and amenities, I think we have gone beyond their expectation. But what happens when they expect us to be empathic and more compassionate and understanding of their state of affair? We kind of give a complete, blank look. That expression that I had shown you in the last session, where we have an expressionless face, that's probably that hurts them the most. I completely agree with you. Yes, Dr. Anuradha, you wanted to add a point. Go ahead, please.
Yeah. Good evening, Dr. Hindu. My only point was that every patient, once a particular doctor deals with the patient or
Mhm,
checks them up,
mhm,
what they feel is each step that has to be taken now should be guided to them by the same doctor.
mhm,
They do not want as the rotation comes and corporate hospital, as we have to change shift, so the second doctor or doctor on duty comes and talks, they would say, not you, where is my
mhm,
doctor? I want
mhm.
my doctor to talk to me about it. So that
Yeah.
is one thing I really feel compassionate to them, that they have to understand in corporate hospital how the work is done, and every doctor is responsible. Either that has to be conveyed to them, or one particular doctor has to deal with them. That is one big point I feel.
So I
That is
completely
the
agree
expectation.
with Dr. Anuradha, what you're saying. So one learning that we have from this is that patient can have unrealistic expectation because a doctor cannot be present 24 hours. So that means, can I read this beforehand, and can I manage it beforehand? Because if I know we will not be able to keep one doctor 24/7 for 1 week for a patient, which is practically impossible, doctor or a nurse or anybody. So that means either all the doctors have to proactively build rapport with the patient and win patient's trust that we all are responsible, or the handing over of the patient has to be done in such a manner that the patient feels that, okay, my doctor is going now, this is my next doctor. I don't know how many of us really go and tell them, okay, I'm getting off, and now in my place, this doctor or this nurse is going to look after you. We hand over, but we don't inform the patient that who is going to be your next doctor. But then this point is very well taken care.
Dr. Indu,
Yes, yes, doctor.
can I say
Yeah,
something, Dr. Indu?
please,
Acha, so
ma'am, go ahead. Yeah.
one thing that I couldn't agree more with the Captain Sandhya, because empathy is now being in a cancer hospital. That is the first expectation a patient has in my hospital, and secondly, because of the nature of the disease, they want that the doctor should be absolutely clear, and they somehow there is a kind of an expectation that without their asking, the doctor should be telling them about their survival, about their prognosis, and these things they don't want to clearly ask because they're so scared of the word cancer. So there is some kind of extended expectation, I would say, that it is expected by patients, a different kind of expectation.
Yeah. So completely understandable what you're saying, because probably the word cancer itself is very scary, and anybody's apprehension, anxiety, fears would go to any level. And I think proactively, as healthcare providers, not just the doctors but nurses and everybody who is handling this patient, should be sensitive to the patient's state of mind, and should be forthcoming in managing and addressing this anxiety and fear, and kind of comforting them in by providing them a proactive information. I completely understand your point of view. Dr. Rajesh, you wanted to say something. Please go ahead.
I think everybody has cited all the change in the patient,
Yeah.
what is it, their expectations. So that is why NABH and other quality, accreditation bodies have said patient-centered care. One thing is that one is to give good care, good ambience, and also behavior from top to bottom. But other thing is also to communicate that this care has been given.
Yes.
That is equally important. Maybe we have done it well, but we have not communicated it well. That is
Very
also
right.
one very lag in our services.
So that means not only we have to give good care, but we have to demonstrate
Communicate.
and showcase that I have done a good job, or I have and informing the patient and the family that this has been done. So this is again, I remember I told you, I think in one of the last classes, that it is something like, we do everything, but we don't inform the patient and the family. So it is something like winking at a girl in dark, that but she does not. So you have to make it obvious and make it very clearly known to the other person that I have done all this.
That's such a nice example. Nobody will forget.
I always say this, that when you do something, you got to make it, be seen and also, acknowledged by the other person. So I think a lot of input has come from all of you, and I understand that at least we understand that these expectations are there. But honestly, I'm sure many of you may be struggling with the idea that are these expectations really getting fulfilled at the ground level? That's $1 million question. And I think that as quality implementers, or as trainers, or as executives in our place, we all are struggling with how do we make this happen? How do we help our staff understand patients' expectations and see how they can fulfill whatever is possible in their own capacity. So this topic I deliberately kept in the beginning of the next 6 sessions, because most important is to sensitize the staff about patients' expectations, because this is where we struggle. Staff would give good care, staff would give medicine, injection, nursing care, or whatever medical intervention is required. But when it comes to understanding patient expectation, usually we think that it is something unrealistic or something that's not in my review, or I'm not supposed to be, attending to all this. But whatever you have said, is anything unrealistic out of what you have said just now? You think anything is unrealistic?
Not really.
No, no.
Not really. So if we put ourselves in the patient's position or patient's family member's position, I think all this is so very justified. So take 2 minutes, just 2 minutes, to yourself. Recollect any one incident that you have recently experienced, either as a patient or patient's attendant. Because I know we have gone through COVID era, so many of us must have experienced either COVID or maybe something non-COVID, but serious something. So just try to recollect that incident and note down the expectations that you had as a patient or as a family member. And on the right side, write down, was it fulfilled or not fulfilled for yourself. Take 2 minutes. So your time starts now.
Can I just repeat once again, please?
Okay, sure. So take a copy and a pen. Try to recollect any recent incident where you were a patient or patient's attendant, not in your own setup, because in your own setup, you're VIP. You would get all possible care and attention. But when you go to a different place where you are not known like to anybody, so you have gone as a patient or patient's family member or attendant, just try to recollect your expectations from the healthcare providers. And on the right side of that expectation, write down, was it fulfilled or not fulfilled? Just write a keyword. You don't have to write the whole thing. Just write the keyword that staff should smile and attend to me, or somebody should listen to me, or somebody should answer me. Even that small thing. And on the right side, write down fulfilled or not fulfilled. Take 2 minutes. So you can write done in the chat box if you have done it, so that I know we all have finished. Okay. So if I ask you the number of expectations fulfilled in terms of percentage, will it be possible for you to immediately calculate and tell what percentage were fulfilled? You can write your percentage in the chat box. Mm. 20%, 65%, 20%, 30%, 66%, 14%, 60%. Imagine being from healthcare. If this is what we get, what must be patients' expectations being fulfilled? 20%. So I think this should give us a fair idea about how disappointed our patients must be. So this should be one of the topics you should be discussing with your audience whenever you plan a training program. I will advise you. And the pedagogy that I will recommend you here is not to straight away ask how many of your patients are satisfied with your this thing. They're going to say all of them are more than happy and satisfied. The best way is to start with case studies. So give them a situation and just let them read the situation and then ask a couple of Socratic questions after the case study and make them reflect on their conduct when it comes to actually handling real life situations. Most of them will actually be able to see their real life behavior in those case studies, because that's what is exactly happening across the hospitals, be it government, be it corporate hospitals. As many of you said, the expectations in corporate hospitals are different. The clear reason is because they're paying for it and they want value for money. So it may be a little rude comparison or rude analogy, but when we go for a cup of tea or maybe for a family dinner, what do you expect from the place? Good food, good ambience, and good behavior. So suppose if any one thing is missing, will you really say, oh, this is a good place? Will you really recommend to anybody to go and eat there? Similarly, I think understanding patients' expectation is one of the primary responsibility of healthcare providers. And if you can look after that, half the job is done, because then you know what your patient is expecting. And patients' expectations are not static. They're very dynamic. So what are patients' expectations when they are entering your hospital? Suppose if they're coming to the OPD or to the emergency, what are their common expectations? Anybody?
They have to be attended immediately, ma'am.
They have to be attended immediately. Very true. What else?
All the information to be given to them immediately, what is to be done there.
So whatever
then
is being done,
they can arrange for it, either money or other attendee or anything.
Very
Their
true.
time, they will understand.
So for example, if a patient has come to the emergency, the initial expectation will be, please attend to me and relieve me of the suffering. It could be pain, it could be bleeding, it could be injury, it could be anything. But after a while, their expectation is going to change. It's not going to be over. It's going to be different. And sometimes these expectations bother us a lot. So let's do case study 1. I hope you all had a chance to read. Did you get a chance to read?
Yes, ma'am.
Yes, ma'am.
Okay. So if all of you have read, then I don't think we need to read the case study. But if you have not read, then maybe we will have to read the case study. So who all have not read? Raise your hand. Anybody who has not read? Dr. Bala, Reena, and Captain Sandhya has not read. So, chalo. Then three of you will be reading 1/3, 1/3, 1/3 of the case study for all of us because you haven't read. So, Dr. Sorina, will you start reading case study 1 for all of us? Page 33 or 32, what it is?
33.
Unmute your device, Zina. I'm not able to hear you.
Just give,
booklet
me a
is not.
minute, just give me a minute. I'll just get the printout. I got it to read, but I couldn't read. So I'll just get it.
Okay. So Captain Sandhya, you have it ready with you?
Yes, I have.
So, and Dr. Bala, you also have it with you?
Which page number 35, isn't it?
Case study 1, yeah.
33.
I checked, it is 33 or 35?
33. 33.
Okay.
Can
33.
I?
Yeah. So let Reena join and then, yeah.
Right. Shall I start? Right.
I thought let her come back because otherwise then she will miss the reading.
I will. We will wait.
I'm here, ma'am. I'm here.
Okay. Yes, Dr. Captain.
Right. Managing patient expectations. Case study 1. Ready, set, go. Right after dinner, Abdul Rahman clutched his chest and told his wife, Zeenat, that he thought he had a heart attack. Zeenat wasted no time getting Abdul and their 16-year-old daughter Katrina into the care and raced to a nearby hospital. Although the ER was quite busy, Abdul was placed into a room immediately and attended by Dr. Raghavan and the nurses on duty. After taking the history, the team checked his vital signs, including pulse rate, blood pressure, breathing rate, temperature, and auscultation. All preliminary tests were normal, and Abdul noted that his chest pain had also diminished. I'll be back in a while, Dr. Raghavan said. The nurses also left the room, going outside to take orders from Dr. Raghavan. Zeenat held Abdul's hand while he was still lying on the examination table. Katrina began to cry. Dad, this is scaring me so much. I don't know what I would do if anything happened to you. I'll be fine, Abdul replied. I'm feeling much better already. I bet they will let us go home very soon. 2 or 3 times during the next hour, one of the nurses looked into the room, scanned various instruments, and left. Another hour passed, then another. I think they forgot you were here, Zeenat said. They know you're fine, or the doctor would be checking on you. I'll find someone and see if they are finished with you now. I'm getting impatient. Just sitting here with nothing being done and no one telling us what's going on. Zeenat went to the large circular desk in the middle of the room and asked a nurse if it was all right for Abdul to leave since they had been in the room, most of the time alone for quite some time. I'll ask Dr. Raghavan, a nurse said. It may be a few minutes. He's with another patient. We might as well leave. He's feeling better. And there doesn't seem to be a reason to sit around here, said Zeenat. When the
So,
nurse...
Captain Sandhya.
Yes.
So let Reena continue.
Sure.
Yeah. Go ahead, Reena.
So when the nurse saw Dr. Raghavan, she asked him, Doctor, Rahman's wife just said that they want to go as nothing is being done, so he must be fine. So she thinks that they should leave. That is ridiculous, said Dr. Raghavan, almost shouting. So she is bored and wants to go home. Tell that female that this isn't about her and her comfort. It is about the patient. Tell her no. I am not releasing the patient until we have completed our monitoring and we are certain he is not at risk. Katrina had wandered outside of the exam room moments earlier and couldn't help but hear this entire conversation through the conference room door. She went back to the room and said, Mom, it sounds like the doctor is pretty mad at you. You're kidding, Zeenat said. What for? He thinks you want Dad to go home just because you're tired of sitting here and that you don't seem to care whether Dad is well or not. He told a nurse. Yeah.
Reena, let Dr. Bala complete.
Yeah. He told a nurse that they were still monitoring him. They are still monitoring him. How did I know? No one has spoken to us for hours.
Mm-hmm.
They just left us in the little room. I think I will have a word with the doctor. Just as she spoke, Dr. Raghavan entered the room. So, shall I proceed?
I think that's all. Now we are going to talk about the discussion
Yes,
points.
fine. Yeah.
I hope everybody now knows the case we are discussing. So is this something uncommon?
No.
Yes.
Very common.
Wrong way of conveying things. I mean, yeah, it's quite common. Nothing uncommon about it. This always
So
happens.
first of all, about
Yes.
not informing the patient and the family that what we are doing, for how long we are going to hold you, and why we are going to hold you. By the way, why don't we normally share this with the patient? What could be the reasons? One by one. What could be the reasons?
To avoid panic situation, like they should not get worried what has happened or what not, to make the situation calm. Maybe.
But do you
I
think that
think
really helps to reduce panic?
No, it does.
no.
Yeah. Captain Sandhya, yeah, you wanted to say
Uh,
something.
It's also, if there's nothing wrong with the patient, we don't prioritize, and we don't feel important to communicate to the patient.
Hmm.
There's another thing that if we communicate, then there is another series of questions I'm going to encounter, which is going to eat up my lot of my time.
Hmm.
So this happens. And
This happens.
second is, yes, and but in this situation, it appears to be an emergency room, which is actually a very busy place.
Yeah.
And nobody has time to go and again explain another
Explain.
thing. So inter-team communication also was very poor.
Yeah.
They would actually have taken instructions and handle the patient in a better way.
True. Dr. Anuradha, you wanted to add something. Go ahead, yeah.
Yeah, I think a doctor does not communicate all the steps he is going to take in immediate future, because even he has to extrapolate. And if we say within an hour things will be done, the patient sticks to it. Whereas if the patient situation changes, the doctor has to change his whole also the mode of treatment or the prolongation of period for his stay. So the difficulty for the doctor is, it is not a white and black area. There is a big gray area and that patient doesn't understand. So it's better to let them be in, so in a situation
In
where
dark.
they have to
In
wait.
dark.
Not exactly
In
dark, I would say, Dr. Indu, but yeah, not giving 100% of the things to them, to keep something to them also. I think that is one of the reasons
So
doctor
I
takes his
completely
own time.
understand. Sometimes we may not be even sure of what is going to be
Yeah.
done in this case.
Yeah.
Can we communicate this to the patient that we are still kind of observing you, or we have still yet not made up our mind with clarity that okay, you are okay to go, or we still want to observe you? What is the harm if we even tell this, that we are still considering, we are not very sure of your health condition? Do you think patient will lose faith?
Yes, many patients do. They do
So
not
what
agree
would you
with the
prefer?
fact.
What would you prefer? Suppose if you were the patient, what would you prefer? Being kept in dark, or in being informed that, see, as of now, everything looks okay, but still to not to take any chance. We are still wanting to keep you and observe you. And whatever happens, we will let you know. What would you prefer if you were a patient or
Being
attending to the patient?
informed is the best.
Keep us informed.
Exactly. See, we presume that if I tell that the patient is fine or not fine, then I will be, entangled into another situation. But isn't it a safety measure to be very honest and tell them that, okay, as of now, this is what, and on what basis am I taking this call? Your ECG is okay, your heart rate is fine, your pulse is okay, BP, all vitals are okay. And we have yet not been able to find any reason to say that you have some cardiac concern. But we still want to observe you because we don't want to take any chance. But normally we avoid this. Anybody else who would like to comment on this question? Dr. Anup, Dr. Bala, Dr. Pai?
We overlook the dignity to be given to and respect to be given to the patient and the bystanders. However busy you in ER,
Yeah.
the patient comes, it is our very important to say what you suspect in the patient and what plan of care you have. That is basic. That we have to communicate. And if you don't do that, this is what is going to happen.
So if I ask you to look at the case study and just identify, and each one of you need to give one answer, what do you think, what behavior of the doctor or the nurse were inappropriate from the case study? If you can point out one by one, just to gain insight into how we sometimes unknowingly, not behave appropriately. Each one of you, one by one.
So the
Same.
doctor shouting on her that, this is ridiculous. That's
True.
not correct, because on one hand, you're not communicating at all, and the first time you do so, you shout.
Yeah. So because maybe the patient's family is pressing me to speak and I'm not in mood to speak, so I'm getting aggressive and I'm trying to, just quieten them by shouting at them or at the nurse. Okay, very right. What else? Yeah, Dr. Radha, go ahead, please. Yeah.
Yeah, when when doctor found that all the vitals were normal, preliminary tests were normal, and even the patient could make that out. Doctor said, I'll be back in a minute. And the nurses also left the room going outside to take the orders. There, I feel the staff could have informed. We will be back with all other results and doctor's instruction and convey to you. I think that is one point.
So that means when we are coming in the room and going out, we should at least tell the patient that, okay, we are going out and I'll come back and explain you and update you. So in emergency care, a lot of time this happens. Patient would be on the bed and we all come and go and do everything, check the monitor, maybe start the IV, even give the medicine, but we would not talk to the patient or explain what is being done and why we are doing. Very right. What else?
Communication between the nurse and the doctor. So the attender told something, but she told the doctor that she thinks that they should leave.
Wonderful.
So ultimately,
Very
doctor thinks that I am the doctor here.
Yeah.
So that is why he has spoken that is ridiculous kind of thing. So
very good observation, Dr. Bala. One thing, the way nurse went and communicated to the doctor, that aggravated the situation. Had she gone and explained in a very neutral manner, doctor, the patient wants to know how long they have to stay. So can we give them some communication?
Yes.
That's one failure. Second is how he reacted. A lot of time publicly when we behave, we don't realize people are observing us and our behavior is being noticed and being judged. So at a public place, we cannot behave like we behave at home with our family. There is a decorum and we got to maintain that. That's very important. Yes, Captain Sandhya, you want to say something?
Yes. One thing which I distinctly saw missing here was owning the patient. Reason, it's not the doctor is seeing all the patients. The nurses are tagged to the patients on the beds, and whichever patient comes on that bed. You're supposed to own your patient and do everything for them. The moment you own your communication, your language, your words, everything will change. Automatically, because if that responsibility would have been there for, he's my patient, automatically she would have said,
I
sir,
think,
my patient.
Isn't that missing most of the times?
Yes.
Most of the
and that's how that triggers, and that leads to lack of understanding, empathy, everything.
Agreed.
So
Pooja, anything that you observe? Yeah.
Just one feeling. This is if we keep talking that this is my patient, the language changes. Doctor, my patient is waiting for 2 hours. What should I tell her next?
Yeah, exactly.
This would have been magical.
But I think that thing is completely missing, that my owning the patient is completely missing. I completely agree with you. Pooja, did you observe anything that is missing in the communication? I mean, anything in terms of their behavior, doctor's behavior or nurse's behavior?
Ma'am, actually that patient attendant name was Zeenath. She was actually feeling very alone and helpless. Means she was not like to whom she could ask, and nobody was responding themselves. So one thing I think we miss, because we are nurses, so we just go and we give the treatment, we give the medicine. But we never say, okay, if something will happen or if this will get finished, just call on the call bell, or I'll just come after 10 minutes, or I'll just be back after 5 minutes. So I think this thing is missing. That's why she felt that, okay, if they are not telling me, so I can ask myself that what is going to happen, because she was having no idea that if everything is normal, everything is okay, then why they have kept here in this emergency with cardiac monitor and all. So the way she asked, but how she interpreted the nurse and how she communicated in another way around to doctor, and then again that cross reaction, it was disastrous.
Completely agree. And imagine it was not a minor injury. They had come with pain. So pain means I have cardiac condition. Cardiac condition means I can think of death as one of the consequences. So the moment you start thinking like this, your whole process, of processing information completely changes. Nobody addressed that part, of course. Nobody talked to them about that or raised, address that concern completely. So what all could have been done? Just quickly, I know we have discussed it at length. What all could have been done?
Hello.
Sharmisha, do you wish to say something? I think Sharmisha has
Yeah.
please.
I fully agree with what Captain Sandhya is told. Even we have seen with the nurses, many times they are not even the pronouns with the patient name. They just told cot number this and cot number this and room number this and this. So ownership is totally missing. I completely tell this 75% nurses, they don't like to tell this patient by name. They are just, speaking with this room number or the cot number. So the ownership is really lacking in this patient expectation.
So, Sharmisha, I think as a policy, we should insist on calling the patient's name, then
Yes.
calling the patient's bed or room number or cot number. I think some of you are already in administration, and positions where you can insist on this, that let us not call bed number or room number, or sometimes even disease wise we call, that patient with appendicitis, or that patient with malaria, or that patient with COVID. So we have to bring this cultural change by calling the patient's name, that patient so and so on bed number so and so, to make sure that we are talking about the same patient. Very right. So very quickly, what all could have been done to not have had this situation the way it happened? Yes, Dr. Anuradha, please. Yeah.
I feel where it is written 2 or 3 times during the next hour, one of the nurses looked into the room, scanned various instruments and left. Another hour passed and then. So just a small change here. If the nurses, whosoever was coming and looking at the instruments, just gave 2 words, we are monitoring, ma'am, we'll be back in an hour. We are monitoring, ma'am, his conditions will be back. Only that would have assured them that they are under
even while the
supervision.
doctor was going out, Dr.
Yeah,
Anuradha, when the
yeah.
doctor was going out,
could
he
have
could have at least informed them that this is what I see right now.
Correct. So
If
that
ECG
change,
is okay, vitals are okay, he seems to be okay, let us see, let us
Yes.
observe. So that means communication from the doctors could have been, proactive. Communication by the nurses could have been proactive, and they visited multiple times
they did.
his room.
Yes.
They could have, talked to them. Okay. Anything else from others?
And one thing is that the doctor should have told the patient that your ECG is fine, like we're just keeping you for observation. So that should have been communicated first.
Yeah.
The other thing is that nurses, since the doctor has not communicated anything, the next thing was the nurses. So they should have told that the doctor has told that everything looks okay. So we are
Correct.
just keeping you for observation.
For observation.
And the third thing is
And
with
patient
the
would agree.
Yeah.
Will patient agree or not if you say we want to still observe you?
No, ma'am, since it's a chest pain, so we can, the doctors normally tell that. So now the ECG looks fine. Generally, we'll have to repeat it after an hour or something like that. So I think the patient will wait.
Would agree.
The other thing is the miscommunication between the doctor and nurses. So which should have been avoided or put in a better way.
Yeah.
I think,
He could have communicated responsibly and he could have reacted responsibly to it. And also, when you're talking about a patient, it should not be done in a manner that others can overhear your conversation.
Correct,
Even that protocol has to be followed. Wonderful. Any other point from anybody before we move on to the next case study?
I feel, Dr. Indu, that even the inherent coordination communication between the clinical treating team
was
also not clear. That is why there was a discord between the two parties, the nurse and the doctor. So I think it's the clinical work, we all understand, needs a very, very intimate coordination between the teams, which was lacking, I think.
And also a lot of time, the medical management is completely considered as doctor's prerogative. And they do not communicate their clinical diagnosis or what is the plan of action, even with the nursing staff.
Yes.
So it's more like whatever instructions need to be given to the nurses that are given, but they are not updated about what is the plan of action that the doctor has on his mind or her mind.
I'll
So
give
as
an
you said,
madam, that in many of the ERs there is sometimes one specialist And there is other support staff, the ER technicians and nurses and junior doctors. So if this specialist is looking at critical patients and at diagnosing them, or taking a decision, the rest of the part should be very well handled by the rest of the team. As you have
Yeah.
also clearly said, the rest of the team should compensate for his time which he's
Exactly.
not able to give to the patient.
Yeah. So had he informed his team or his nurses that this is the plan of action, even if he was busy and occupied, the nurses could have communicated with the patient and the family that this is the plan of action and this is why we are keeping you still under observation. So it might seem to you that we are not doing anything, but we are monitoring you and we are, we have kept you for observation. So even that basic communication could have helped the patient, understand why we are here. So patient wants to be informed what is being done and what is the plan of action that they want to know. Earlier, that was not the expectations patients had, but now they want to know, especially when they're paying for it. Now imagine if we have kept the patient and the patient is going to be charged on hourly basis, because I have seen in emergency care, some of the hospitals are charging on hourly basis or whatever facilities they are giving. So patients want to know that why should we be here if I'm fine and if I can go back, then why should I be staying, beyond a point and paying you unnecessary? So those concerns need to be addressed. So I was looking for, some study that could help me understand what are patients' expectations. I didn't get any from India, but I got a beautiful slide from Sri Lanka. I'm going to share with you just to help you understand. See, patients' expectations are very minimal. Very minimal. If I compare it, the Indian continent with the Western world, it's very, very different. I think it's very low, but at least those expectations can be looked after and managed to send the patient satisfied. So I found this interesting. I'm sharing with you this, a small slide okay, let me show you this. I hope the slide is visible to all of you.
Yes, ma'am.
Yeah. So if you look at this slide, some of the things are very relevant. On the first, this thing column is patient's expectations. If you can read the title, patient's expectations and doctor's perception. The second column is about doctor's perception about the same. So principally, they both agree that yes, they should greet each other and the doctor should welcome and should smile and, before they start the consultation, and doctor should invite the patient to sit and talk. But if you go a little below, like for example, 1.5, the doctor should get engaged in a small talk with the patient before starting the consultation. Now, if you look at the Western training, small talk before the big talk is a norm. I am doing a program with ACH. So they are training us that before you start talking about the actual problem, you have to ask things like, okay, where do you live? How long did it take you to come here? How's the weather? Oh, thankfully it's warm or it's cold. So like these things. But in I think India and in other subcontinent, they are not that, they are not expecting the doctor to talk about, about small talks. Again, if you go a little further, 4.1, again, a very interesting finding I found. The doctor need not ask about patients' views and opinions about the disease. See, in Western countries, it's a norm to ask, what do you think your problem is? What has caused this problem? What is your idea about it? I don't think in our country we ask anything like this. Even the patients don't expect anything like that from us. And if you go a little further, 6, the doctor should decide the most appropriate treatment modality instead of discussing the available treatment options with the patient. If you look at the answer, patients say 83% of the patients have agreed to this, that we are okay with whatever doctor decides. Although doctors are slowly now moving to the idea that they must give details of the other options available. But if you look at the patient's point of view, they do not expect much. But at the same time, talking about all this really helps build rapport and also win their confidence. And then number 7, the doctor should not involve the patient's relative in the treatment of the patient's disease. Again, only 50% of the patients expect the family to be involved or to be, informed about this. Otherwise, most of them are okay with whatever the doctor decides. Looking at the second slide, I found some of these findings very interesting. So I thought I must share with you. If you look at number 10, doctors do not entertain the patient's point of view and ideas about the disease. So 29% of the patients feel that yes, their point of view is not, asked for, or is not clarified, or that's not checked for them. Any other interesting finding you find in this slide? If you look at 16, doctors do not pay respect to their patient's point of view and opinion. 33%. On the patient, on the doctor side, it's almost like 50%. Look at 17. Doctors should involve the patient when deciding the management of the patient's illness. 80% or 83% of the patients want to be involved about when they are deciding the management of the problem. So I think it gives us a fair idea about what patients expect from us. And we really need to, understand these expectations and, address them. So let's move on to the second case study, and then we'll have a look at how can we categorize these expectations, and then, keep them in mind when we are handling our patient. So case study 2, I hope all of you have read it. Anybody who has not read it? Reena, you have not read. So anybody would like to take the responsibility of reading? Dr. Bala, you have also not read?
I read it, madam. I read it.
Oh, very good. Captain Sandhya, you have also read. Okay. Only Reena has not read. So can we quickly read it, so that we are all on the same page?
Ma'am, you want me to read it?
Maybe yes, if you're okay.
Yeah, sure.
Yeah.
So managing patient expectations, this is case study 2, de-stress in the labor room. Miss Anita and Mr. Shekhar have been married for 5 years. They had shifted from their hometown, as Shekhar was a captain with the Indian Army and was posted here. So they were pleased when the doctor who evaluated and treated them for their infertility told them that Miss Anita has conceived. Following this, they had been carefully going for regular antenatal checkups, blood and urine tests, USG scans, and taking all the medicines prescribed by the doctor. The whole family was anxiously waiting for the arrival of the baby. It was about 3 days before her date of confinement when Anita said, Shekhar, I can feel some pain in the lower abdomen. The baby is kicking too much, and maybe I'm in labor. This alarmed Shekhar, as the doctor had told them that if she had pains, bring her to the hospital immediately. So they decided to go to the hospital. By the time they reached the hospital, it was 6 p.m. As their doctor, Dr. Sunita, informed, they went straight to the emergency room. Anita was now getting more frequent pains that were hurting her back. As a result, she was unable to lie down. When Shekhar entered the emergency room, he was shocked. People ran around everywhere and all the beds were full of patients. He didn't know what to do and whom to approach. Meanwhile, he saw a nurse who had just got free and was washing her hands. Sister, my wife is having pains, said Shekhar in a little worried tone. He was not welcomed by a very happy gesture. So what do you want me to do? Talk to the doctor on duty and wait for the triage nurse. In the meantime, make her lie down on that trolley. The pains were slowly increasing in frequency and intensity. Meanwhile, the doctor examined her and asked the nurse to shift her to the labor room. Anita, can my husband be with me during the labor? Nurse, no, men are not allowed. Anita, but Dr. Sunita had told us that there were birthing suits and family are allowed in those suits. Well, she's not on duty, but can you please inform her the admission into the labor room was not a welcome sight for Anita. Women everywhere uncomfortable with pain. The doctor on duty examined her and without telling her anything, asked the nurse on duty to give her an enema and start intravenous fluids. The pain was severe. Everyone was busy and she could not talk to anyone. She missed her husband very much. Shekhar was now very anxious. He was waiting outside the labor room and it's been 6 hours since Anita was wheeled into the labor room. No one had informed about what happened to her. He had so many questions. Is she all right? When will I see her? Has she had a dinner? Is the baby okay? When will she deliver? Tired, he just dozed off on that uncomfortable cold chair. It was 1 a.m. when he heard his name being called. Mr. Shekhar, Mr. Anita Shekhar. With a mask on her face, this doctor called out his name. Yes, I am Shekhar, he answered. Where were you? I've been calling out your name for the past 15 minutes. There is some fetal distress, and we suspect that the baby has passed meconium. So she needs an emergency LSCS. Please sign here and give your consent immediately. But doctor, how is Anita? Will the baby be all right? We will inform you, was all that he got in reply. These 60 minutes have been the longest ever for Shekhar. What was happening inside? Is Anita all right? Is the baby okay? What is fetal distress? What is meconium? Once again, he heard his name being called out. Mr. Shekhar, Mr. Shekhar. He ran to the OT door. See, this is your baby. Is this a boy or a girl? See, the baby has to be shifted to NICU. The doctor will talk to you later. She's busy now. Will our baby be all right? How is Anita? When can I see her? But we were told that it would be a normal delivery. Everything was normal. Yeah, that's it.
So again, is this something very unusual?
No,
Very common. No?
Common.
common. It's common. Very common.
It's very common. Yeah. So what are the usual apprehensions? Yeah, please. You want to say something?
Worst kind of experience you can have, you can give to a patient and bystander.
Agree. So my question to you all is, what are the apprehensions of the family when the woman goes into labor and she's, under your care? What are their apprehensions?
Being a primate, she was a primate. It was the first baby. The anxiety and apprehension both are at peak, and not only for the mother but for the husband as well. So first one is, very high level of anxiety and apprehension both. And yes, Dr. Anuradha wants.
And
okay.
Dr. Sandhya, I just wanted to say, even a very precious baby.
Yes.
Case of infertility and then conception.
It was a precious baby.
Primary and a precious baby. That's all. That's it. Please continue.
Yes,
We find there is no communication at any stage, of this whole story. There is total lack of communication, and nowhere we have seen any, anything of any quality and
communication, proactive communication.
Yeah. Very, very poor.
So a real life experience that I want to share with you, in one of the government hospitals, a lady was admitted with false pains, and she had her mother-in-law around her during her stay in the hospital. The mother-in-law was very apprehensive, so she kept going to the resident asking that she has pain, why don't you come and examine? Please check if the baby is all right. Please check if the mother is all right. The resident, like, sometimes we are busy, sometimes we know that it's a false labor pain, so nothing much has to be done. So she just did not go to see the patient. And the lady went out and she told her son that these doctors are not attending to your wife. Either she will die or the baby will die. They're waiting for mother or the baby to die, so they are not looking after. Now imagine the way it got communicated. He comes in, starts arguing with the resident on duty, becomes aggressive, starts hitting her, literally tore her clothes, that you are acting irresponsible. At the end, yes, he apologized, even she apologized for being not, going and attending to the patient or communicating. She could not continue practicing in the same setup. I mean, she was so traumatized with the experience. And the failure was so minor, which could have avoided this whole incident. She just needed to examine, or if she was sure that it's a false labor pains, she just needed to inform the mother that this is false labor pains. Don't worry, we are observing your patient and we are also looking at the child. So don't worry, they are under good care, and that's all. So these small communications, when they are not taken seriously, it can be catastrophic. In another government hospital, this patient was hospital employee's wife, and this was one of the medical superintendent who shared his experience with me. He said the lady delivered a normal child, normal delivery, was moved to ward, and then suddenly she had a feeling that she's bleeding more than normal. She asked her mother-in-law to go and inform the doctors and nurses that I think I am bleeding more. So this mother-in-law went to the nurses station. There were doctors, there were nurses, and she told them that please come and see. She's saying I'm bleeding more than usual. Okay, we'll come. Okay, we'll come. But nobody went to see, and slowly the time passed. After almost like 1.5 or 2 hours, when the lady literally started fainting and losing consciousness, the mother-in-law rushed again to the the nurses station and asked the nurses and the doctors to come and see that she's becoming completely dizzy. They came, they checked on her. She had gone into PPH, tried to save her. We lost the lady. So that's the seriousness of the situation. Sometimes we think patients are expecting a lot from us, or they are bothering us, or they are asking us to look at them frequently. But that's not the thing. I think every complaint given by the patient should be taken seriously, even if it's something like not very big thing, but you never know which is the bigger one and which can end up into a major. So these 2-3 incidents really shook me that we need to be more alert when patients come up to us and tell us about their condition. We should not take it lightly. So similarly, in this case, what we have seen, although fortunately the baby was saved and the patient was saved, but what happened to the patient's mental health? And I'm sure you all would agree with me. I have seen this in government hospital. I'm sure it must be the same thing in the, if not same, but it could be something similar to it. I mean, we literally had to design this world called respectful. What is that? Mother? What respectful is a word called? Maternity care? Or respectful delivery? Something like this. I have
Motherhood.
Motherhood, yes. Respectful
Respectful motherhood.
Motherhood.
Yes, there's more term. I got to know from this Afghanistan doctors. 2 doctors are joining in the next batch. So I know them, and they told me that we literally had to design this program because we need to sensitize the staff working in labor room that you need to be sensitive to the patient when they are in pain. Labor pains are considered second pain in the humankind. First is, I think, MI, and second is labor pain, or maybe alternate. Imagine, patient with MI we look after so well, but the patient with labor pain, we say, okay, suffer. It's all right. You'll be fine. Don't worry. And then we ridicule, we make fun of them. In government hospital, I've seen it personally. They would laugh. They would laugh. They would tease. They would pass comments when the patient is, crying in pain, in labor pain. So that's something that we need to be, train our staff to be more sensitive about, that we need to be, more compassionate and understanding that anybody who is, experiencing labor pain is in real pain, and we need to be more considerate with them. So if I ask you to look at the case study, what all happened? Where all communication lapses happened? Can you identify? And one answer by one person. Yeah. Everybody should contribute.
You are talking about respectful maternity care. That is
Yes,
WHO,
respectful maternity. That's what. Yeah, respectful maternity care. So she told me that we have a program running called respectful maternity care because we are very insensitively handling the mothers in labor pain. Imagine. Of course, in the corporate sector, it is different. But again, are we really empathic with the patient? Are we really, understanding the severity of the situation? That's a question to be asked. So, what all could you observe in the whole this thing? By the way, what were their expectations? What were their expectations? Shekhar's and his wife Anita's expectation.
So they are told about the birthing suits and all. So instead of that, they have gone to the emergency room. The moment they enter the emergency room, they have started that they want to. They have seen all the emergency cases.
True.
So the fear started from there, and
right
goes
there,
on.
there should have been a communication that, okay, we have offered the patient a birthing suit and we got to make sure
Yeah.
that we have one for them. If we
Yes.
have planned that, we should have one. So there's a communication failure, there's a coordination failure between the
Yeah.
doctor and the other team member. Wonderful. What else? Yes.
Ma'am,
Yeah.
the nurse could have been empathetic because what if her shift is getting over? She should
Yeah.
have expressed, oh, okay, we'll just take care of it. So she could have called another nurse
Yeah.
or just given 5 minutes to help out.
Yeah.
So this
Or
could
hand
have
it over to a responsible person that, okay, I am moving, but there's a person who will look after you.
Yes.
Dr. Leah, what is your feeling?
In the beginning, when the doctor, when the husband was approaching the nurse, then the nurse said, "So, what do you want me to do?" So that point, yes, that has
Imagine how
created
insensitively, yeah.
yes, yes.
Completely agree. Dr. Anoop, anything from your side?
Here, the couple was offered a birthing suit and was told that the family will be allowed. So, but that was not, since the doctor
Again, a
was not
confusion.
available, that was denied. So
That
there should have been a better communication between the doctor and the hospital staff,
yeah,
saying that
yeah.
these types of things are available here.
Agreed. Dr. Anuradha, you want to say something?
Yeah,
Please go ahead.
it says here that when Shekhar was little worried and he said, "Sister, my wife is in pains."
Yeah.
So he was not welcomed by a very happy gesture. So his expectation was a happy gesture saying, "Yes, we'll take care. Now she's here," or something.
Assurance that, okay, don't worry, we are there to look after and we will manage. Don't worry, we are there to. It could be the doctors, it
First
could be the nurses.
initial stage. Yeah.
Somebody should have actually. Completely agree. So if those of you who have got my book, if you will read the prologue, I don't know if anybody has read that. I have written my journey as a first time, a mother. So I remember I had gone to Lady Hardinge Medical College because my husband was doing his post-graduation from LHMC. So Dr. Padu Bidri, who is considered mother of, gynecology and obstetrician, and she has a number of books in her name. So she was the one who was, under whose care I was, and being, my antenatal was under her care. So I got admitted in LHMC. She said, on 14th, I have a conference. So let us admit Indu on 13th and induce, labor pain and then deliver, and then I go for my conference. And then we all agreed. I said, okay. So I got admitted on 13th, and by evening, there was no progress. It was absolutely not progressing. And she could have left me easily on somebody's head. But she said, no, you have been under my care. I will cancel my going to conference. She made me rest. There was another very senior doctor who was my husband's, head of the department's wife, Dr. Mrs. Lamba. So both of them decided that no, we need to give her rest, give her time, and then make her deliver tomorrow and let her rest tonight. So they made me sleep, and then next day morning, they again, induced pain, and then I had a, delivery. That was the level of commitment of the today. In one go, we decide. So I think if we look at especially this case study, it tells us that I think that's a very critical care time for the patient and the family. I'll just quote one more case here to just help you know how sensitive is the issue and how carelessly sometimes we handle. Rather, I'll share two cases with you. See, one, that's again a case that happened in my knowledge, a relative of mine. This lady, Primey, she delivered a, dead fetus, male child. And I don't know, like somebody, around kind of announced very carelessly, the mother was conscious. It's a dead fetus. Arey bachcha to mara hua paida hua hai. The lady heard it. Within few seconds, I don't know, what happened, and she went into amniotic fluid embolism. She was moved from that hospital to another bigger hospital, tertiary care hospital, moved to ICU. And after few hours, the hospital knew, who were shifting, they knew that the mother's condition is absolutely, irrevocable. She's not going to make it. Within few hours, a call goes from the hospital to the husband. Please come and collect the dead fetus. The lady is in ICU. Please come and collect the dead fetus. There are cats and rats around. It can be eaten by them. Now imagine what would have happened. They were really shocked and they were very angry. As it is, the death of the woman and the child was so painful for them, for the family, because it came as a shock to them. You are going for an excitement, and then suddenly you hear something like this. It's a complete, catastrophe for them. And over and above that, if we are talking to them in such an insensitive way, imagine the outcome of such situation. So it's not only proactive communication, but also careful communication that we need to remember when we are dealing with such sensitive situations. So I hope this case study gives us an idea how important it is for people who are working in critical care areas like labor room, OT, ICU, emergency. We need to be far more careful when we are interacting with the family, understand the family's expectation, and address them amicably. Any other thoughts about this case study?
Yeah, we should respect the feelings of the husband or the attendant.
Yeah.
The 60
We normally
minutes.
ignore.
Yeah. So we are personally, yeah. So I am experienced that same scenario.
Okay.
Like waiting for outside the labor room and waiting for reply from OT. What happened to my wife or the expecting child and all.
Yeah.
So, but sometimes most of the time we will not like give importance to that attender.
Yeah.
To inform them about we are trying or what we are doing inside the OT. That should be taken care of well, particularly the labor cases.
Yeah. So even allowing the attendant to go and see the patient is also very reassuring for the family.
Yes. Yes.
Yeah. Although in Western countries we allow the husband to be around when the mother is in labor pain, and they deliver together. It's not still 100% in India. In some of the hospitals I have heard that now they're allowing it, but then it's not still a very common practice, not a very regular practice. But at least updating them or allowing the family to see, and especially there is no female attendant. That means there will not be anybody to attend. For example, in this case, there was nobody else. They were on a posting somewhere, and the husband and wife were alone. And there is a possibility of such situation. So if you say male attendants are not allowed and there is no female attendant, that means there is nobody to talk to the patient. How lonely the patient must be, how apprehensive she must be, and she's not being updated. Husband is not being updated, like Dr. Bala said. How would you feel at that situation? I think you will be able to empathize with that. Captain Sandhya, you want to?
Yes, I have one point. I noticed that there were wrong expectations being set from the beginning. Reason being, because Anita did say to the nurse that Dr. Sunita has told us that there are birthing suits in the hospital and families are allowed. Because if that would have been the practice in the hospital, the labor room staff would have been aware about it. But nurse, she just said that, well, she's not on duty. So there were wrong expectations and wrong information given. Maybe yes, the obstetrician must have thought that she will talk because she was in a position to have the family allowed. So this is one thing probably I feel from the beginning it was inappropriate.
I agree. Dr. Anuradha, you want to say something? Yeah.
Yeah, another thing is I feel we take good care of patient. Actually, we try to take good care of patient, but regarding the attendees, there are not good places to sit and wait out because they are in the same pressure, they are in the same pain, though they are
more
not
pressure than the patient.
Yeah. So here that fellow, he sat in an uncomfortable cold chair the whole night and he slept there. So that is mentioned, which says how difficult it is for the attendees to cross that one night or to wait out till they get the good news. So that should be taken care of in hospitals. That equal care should be given to that.
I think now that
As a
picking up,
human
and especially
touch.
the corporate hospitals are really picking that up, and they are, giving good care to the, although we consider it as luxury or as, unnecessary facilities, but then I think it's time that we understand more than the patient, the family also, or more or same, equally they suffer because they are outside and they are worried and they are, drained out in all terms. I always tell to the government doctors that patient is far more comfortable than the family. Patient at least has a bed, nursing care, food, and the medicines. The attendant is normally outside in the corridor, lying on the floor, and no place to sleep or rest or take food or even for their, biological needs. They can't go anywhere. So that's the state of affairs. So we need to be more considerate and compassionate with the family as well, not just the patient, but understand what they are going through. I think your point is very well taken. So I think this gives us some idea about how their expectations are different in different places, and people who are working in those care areas need to be aware of these, requirements and expectations, and we need to proactively fulfill these things. Dr. Pai, you want to say something?
Yeah, three points. One is regarding, as Dr. Anuradha was just mentioning, that he waited all the time, in the corridor whole night, and then the doctor, when she was explaining about LSCS, I called you 15 minutes. I've been calling you, and that is totally insensitive comment to pass when she doesn't know what really happened outside. That is one point. Secondly, the more popular obstetricians, I know in my city here, they themselves come for delivery of their patients. They never leave it to the next. I know one hospital, despite all the competition in the city, has the maximum number of delivery, where the obstetricians don't shy away from, as just like the doctor you had during your delivery. They come and conduct the delivery, whatever may it be, the situation. Sun, rain, or hailstorm or earthquake, they will come. And the third thing is just specific to the other incident which you mentioned of not going and examining the patient. I can quote so many examples from my own hospital where this junior resident not going and examining the patient. They think, I know Dr. Vikram Kashyap, who is a very senior neurosurgeon, and is a trainer for NABH, used to say, always expect the unexpected. So, you go and see the patient.
Obstetrics is a very, very unpredictable branch of medicine. Very unpredictable. Everything will be normal till 9 months. What happens at the last minute, you don't know. So you cannot take it.
You may be thinking you are hearing fetal sounds, but it is not fetal sound.
It could be
and wrongly.
Agree. I completely agree. Wonderful.
That leads to tragedy.
So there are a couple of more case studies also. I'm not, going to do on that. I'm coming to you, Dr. Anuradha. Give me 1 second. So the idea is, Dr. Anuradha, don't leave because I'm going to discuss something very interesting.
I was going to say I have to drop.
It's going to be. There's something very interesting after this. It's your choice, or you may watch video. I mean, your YouTube recording. That's your choice. I leave it to you.
Actually, I'm committed a lot, and I've already pulled on 1.5 hours from them. So I was just wanting to drop that 30 minutes from you. I will definitely go through that. Please,
the theoretical part I'm going to give in the last 15 minutes. That's all.
Don't do that.
No, I have to. I agree. So I have given you You want to
Yes.
leave? You want to leave?
I have to.
Okay.
And Dr.
It's
Indu,
okay.
tomorrow, if you want, we can have from 7 to 9. I'm available at 7 because I'm out of
Actually, I
station.
was about to announce that tomorrow I may not be able to hold the class because we are moving to another place. So we
Okay.
may not have internet there. We are moving today. So
Okay.
we may not have internet for 2-3 days. It will take time to install the next
Okay.
Wi-Fi. So we'll be meeting next Friday. That's what was the plan. But I wanted to discuss about the pedagogies that you all have to cover, and I wanted you to give me your dates so that before you present, you need to talk to me. We need to finalize the content and then you present, because I don't want anything raw to go to everybody. So that's one thing I wanted to discuss in the end, but I wanted to conclude about how can we categorize this expectation and how do we really read those expectations. I was about to introduce a wonderful tool called design thinking. I don't know how many of you have heard of design thinking as a tool.
I will go through the YouTube and your recording,
it's okay.
and I'll
Go
get
ahead.
back to you one-on-one for that, Dr. Indu,
Sure.
for my pedagogy. So
Sure.
please excuse me. Thank you
So
so much.
you need to write the session number because I'm not writing the date. So today is session 5. So who will be presenting in session 6, 7, 8? 2 people will be presenting in each session. It's 2. So you will have to decide between you who will be presenting in the next session, and then the 7th one, 8th one, 9th and 10th one. So that way we will be covering all. Okay. Chalo, go ahead, please.
Thank you. Thank you so much.
Bye. Yeah. So as I was saying that I've given you these case studies to help you think of the training needs that you have for your respective staff or your team or your audience. Based on that, pick up a case study, develop a case study. And if you will make them talk about it, the last question that you can ask them is, if you were there, how would you have done it differently or handled it differently? Ask this question after the case study, and then they will start reflecting. Okay, they will never say I did that way, but then they'll come out with what is the right behavior. So always have a lengthy discussion around case study. Don't hesitate spending time on it, because case study is a wonderful tool to bring them to a point where they develop insight into their behavior. They may not openly admit that this is how I behave, but then they get insight into this is how we normally behave. And then the last couple of questions that you can ask: if you were in the patient's position, what would have you expected? If you were in the attendant's position, what would have been your expectations? Or if you were in that nurse's position or the doctor's position, how would you handle this? And then that will begin a journey for them. So this is a wonderful, session I normally, enjoy doing with my audience, because it brings them to a point where they get into introspecting their behavior and they start working towards modifying it. So quickly, I'm going to share the couple of slides with you, which will be about understanding patient's expectation. Little theoretical part, but then very interesting. Let me quickly, show this with you. Okay, so this is according to a recent survey by Taragni. This is I have a document with me and I went through it and I attended their presentation also. They found out that 45% of the families reported feeling unempowered in the treatment of their patient, expressed inadequate clarity on diagnosis, reported rushed consultation, perceived lack of involvement in deciding treatment, and lack of clarity on treatment and care options. So that clearly shows us where we are in terms of meeting our patient's expectation. According to the same study, 35% of the patients indicated that they are not allowed to describe their condition or symptoms in a proper way. They're not given enough time or opportunity, or they're not asked open-ended question or create that comfort where they can talk about their problem without any hesitation. Also, 32% of the patients indicated that doctors did not straightforwardly address their questions and doubts. And I think you all agree with me, because you are dealing, with a similar kind of, healthcare providers as well as, the patient categories. So have you heard of Kano's model? Has anybody heard of Kano's model? Kano's model? So it's a wonderful model that will give us a very, bird's eye view about the patient's expectation. So this is basically taken from the other, subject, but then it works very well for healthcare also. So patients' expectations can be divided into 3 categories. The first one is basic. So basic is unspoken expectation, and that's expected to be satisfied. For example, if the patient walks into the, say, for example, the OPD, so there has to be a chair where they can sit and wait. There has to be a front desk, front desk where there will be front desk staff who will attend to them. So these are unspoken expectation, and they are expected to be satisfied. Or for example, if we are expecting, if the patient is admitted in the hospital, so getting a neat and a clean environment, getting good bed, or good mattress, clean sheet, this is something that it's not spoken, but then it has to be there, and that's part of the basic expectation of the patient. If these expectations are met, they will not acknowledge you because that's expected to be there. So that is nothing extraordinary that we are doing. But when these expectations are not met, definitely the client will be dissatisfied. Patient will be dissatisfied. So this is category 1. That's called basic expectation. The second category of expectation is called satisfier or performers. So this is something we really need to make sure that we ensure that the patient gets this. For example, these are the expectations. When they're met, the client is satisfied. That means if the patient asks us something, we reply them in an appropriate manner. Or if they have come, we don't make them wait beyond our point. Or if we have given them an appointment, we are ready with the service that we need to give them. So these are the expectations. When they are met, the patient is satisfied. Okay, I was promptly attended. Oh, my reports were ready. Or I was called in as soon as I reached there. I didn't have to wait for very long. But when these expectations are not met, they become a real source of dissatisfaction. Now, a lot of communication expectations are part of this category. So patients want to be informed, they want to be engaged, they want to be involved in decision making. So when these things are not met, they feel dissatisfied. They may not voice, but then they will be unhappy if that's not met. The third category is called delighters. I think most of the corporate hospitals are focusing on delighters. So delighters are those expectations which the patient does not expect us to fulfill. But when those expectations are met, they are really very happy and they go gaga. For example, if we are informing them, you were expected to come today, so please do not visit the hospital. Today is a holiday, or the so and so doctor is not available, so you will, I don't want you to waste your visit, so please we are rescheduling your visit to the next date. So this is something you were not expecting, and you receive a call from them, and you are really happy. So can you give some examples that you have seen your hospitals offering in terms of delighters to their patient? Can you share some delighters? Can you think of? Yeah, Rina, go ahead. Yeah.
Yeah, like in case of OPD patients, so there are patients who come from faraway places, like from outskirts, villages and all. And they have to travel at least 3-4 hours to come to Ranchi and then go back again. So when they come here, they reach in the morning around 10 and meets the doctor. The doctor gives tests. The reports take time to come. Many times it happens that the reports are not available. Doctor has left and they have to stay back, which is not possible. So there, like, we tell them, you please leave, no issues. We will get your report seen by the doctor. He will advise the medication and we will WhatsApp everything to you. And you don't have to come or stay back again. You're saving time. So they don't expect this service, but we do this and they're really happy about it.
They're happy. So good. Yes. Very nice. Wonderful. Thank you for sharing. Yes, Dr. Pal.
Yeah, what we do in Amrita, sometimes the patient does not get a single room, so we give them an upgrade to an AC room, and that makes them very happy, and say does not charge them. We do not charge them extra saying that, required category not available, so upgrade it to EC.
That's a good gesture. Very good.
Yeah.
Any other share?
This is so nice, isn't it, ma'am? In trains, it happened. I had a
Yeah.
third AC ticket. It was upgraded to first AC. I was so happy and delighted.
So good, so good, so good.
Yeah.
So good. So any other experience that, I mean, a practice that is happening in your hospital or you are aware of? Please.
So I would like to share two of those. Every so baby being born is one of the happy moments, and that's the only department which celebrates, happinesses.
Yeah.
And making and offering a complete clay modeling of the baby's feet, and along with, in the palm of it's in form of a POP, or be it plastic, or gel, and with the
Wow.
baby's feet, and the within the mother's hands or mother's feet, or sometimes it's both the parents and holding the baby, and giving a clay model and presenting it to the
Wow.
parents is actually a real delight, that they start, it's something like it's really one of the most emotional moments. But second, very practical one, the organization where I've worked before, a one-stop solution for every need of the patients, families or attendants who are coming from outside, outside city, who have been who have traveled, and this was available for both national and international. Now, it was not only about making bookings for the stay, it is about their travel, their stay, the costs, the food costs, and everything laid out so transparently and so clearly that the footfall was actually very encouraging to see, because they didn't have to do anything. It was only a team working on, it was a concert sort of thing, which catering to every need of the people who travel from outside.
Wonderful.
And if they are not happy or they want something better, options in the city were also made available. This is what analyze in, if it was an international patient, nationally they know how to come.
Excellent, wonderful. So I think now we are picking up like other industries where we are looking at things from the patient's point of view and making sure that it's not just the patient, but the whole family gets looked after, because ultimately it's a complete package. It's not like one person whom you are serving, it's the whole family that you are serving. Wonderful. Thank you for sharing, Dr. Captain Sandhya. I think that was interesting. So again, going back to what we were discussing, delighters are something that now we are focusing at. Can you think of some delighters for the government sector? Although I'm asking you to, think little unconventional, because in the government sector, we think, okay, even if we are giving you basic, that's more than enough. Yes, Captain Sandhya. Yeah.
Booking an appointment through app. Yes. Online appointments. Amazing. It is out of box and it works. It works. First thing. And second, reports.
Yeah.
Reports. So this is the second thing.
So when I went to RML this time for the, for communication gap assessment, so that these were the things I was, telling them, that if you could have a kiosks, where you could get your reports just by, printing your UID number, and then you get your this thing. Even getting the OPD number, people have to stand in queue for almost like 2 hours. And then after they have been seen by one doctor and the patient is referred to another specialty, they can't go directly to the specialty. They have to come back and get themselves re-registered and then go. That means the whole day is gone in the queue. So why not have kiosks where you can go and get yourself re-registered? And so that's how very innovatively we need to look at what can be done to create that, that happiness, that yes, I have been, attended with care, or with, with looking at my requirement. And this is one area where now a lot of, effort is being made, especially most of you are from the corporate sector. So you would like to know what is the way to create these delighters, or even meet the basic needs. So this one slide I'm sharing just to help you see what are the 8 essential elements of patient satisfaction. You may be thinking it is communication with the doctor, but this study says it is communication with the nurses. Second is communication with the doctors. Third is communication about medicines. Fourth is responsiveness of the hospital staff. Like Dr. Pai was saying, it's not just one person, it is multiple people who are involved in the care. So each one of us has to act responsible in a proactive manner. Then pain management is one thing that patients really feel bad when they come up to us and they say, I have pain. And we say, I've given you medicine and you'll be fine. Don't worry, give 10 minutes. But we don't recheck. We don't actually check with the patient, are you feeling better, or are you do you want me to escalate and speak to the doctor? Then cleanliness and quietness of the hospital again is very important. Patients do value it. And the discharge instructions, how clearly they are given, how well understood they are, how do we really check whether they have understood every instruction is something that really patients value. And then overall rating of the hospital. So these are 8 things which I agree that they are really valued by the patient. So I want to introduce you to the concept of design thinking. How many of you have heard this term design thinking and what it is? Okay, Reena and Captain Sandhya. Who else? Who else has heard of the word design thinking? Dr. Pinky, have you heard of the word design thinking?
Not particularly. I mean,
this is a beautiful concept, and it's just waiting to invade healthcare, and it's going to be in a very, very big way in the time to come, because a lot of hospitals are already picking up on this. So Dr. Captain Sandhya, would you like to explain what do you understand by this term design thinking?
Yes. Pardon me if I go wrong in this. The only thing I picked up while I was watching my LND head using this terminology, and I could relate what she was working on this. So I just related this because I heard this term quite frequently in last couple of months. So there's an idea, we conceptualize it, we put it on paper, and on that it is not only an idea listing, it's a complete design on where there is strategy on how it is to be done, there is financials, there is outcome, there is a process flow, is in complete bundle. So Reena, you are an expert, you can pitch in. So it is a complete I would say concept and a model. Like whatever is thinking, it's here, and it's here, it's in various compartments, so everything comes here in form of a sketch diagram, I would say.
Wonderful. I think you have partially covered the concept of design thinking. Thank you so much. Reena, you have something to add?
Captain Sandhya is much more knowledgeable on this. I mean, somebody told me to take a session on design thinking, and I was like, what is that? Okay, I heard the concept. And then I realized, like, maybe it's like the visuals, like we draw diagrams and depicting something. So that is more easily understandable. People can relate to more. So that's what I know of, but not more than that. We are not like.
No, that's all right. See, this is something very new concept. So even if you don't know, I'm not disappointed, but I thought I must bring in here when it comes to patient expectation. So I'll talk about it, in a while. But Captain Sandhya, the example that you gave, that of one stop, counter or one stop place where everything that the patient or the family requires is nothing but an outcome of design thinking. So design thinking is when there is a problem. If you start looking at as a problem, and what are the possible solutions, and how do you really, pick up the solution that's going to work for the problem, is actually the background of design thinking. I'll explain in a while, you will understand it better. But I think those of you who are true problem solvers, you must undertake a program on design thinking. If you want to really, strike it hard with clarity, design thinking is a concept extensively being used across the world. I'll give you a couple of examples and then you will understand what I'm trying to say, because I know it's a little abstract. So many of us are still not, familiar with this. So, design thinking is, there's a problem definition. This is the first one. Problem definition. What do you want to solve? So if I take example of Captain Sandhya, that we have one-stop shop or one-stop counter to attend to the patient and the family's need. So that can be taken as one of the issue that you want to work on. Then the second step is empathy building. So empathy building, how does it happen? you literally do the process mapping with the patient. For example, you start imagining the moment patient needs to come to your hospital. So what all the patient needs to do? They will look for the resources, they will look for the facility. So that means they will Google search. Then once they are able to identify our facility as their resource, then they would like to get in touch with us. So that means there has to be a place where they can digitally connect with us, maybe through call or maybe through email. So you need to have a setup that can look after that. Then once they have communicated with us and they have finalized their coming to us, what all do they need when they come to us? So empathy is more like considering yourself as a patient or their family member and imagining, if I needed this service, how would I approach? Third is ideation. So ideation is whatever ideas you have. It could be something very weird. So everybody does brainstorming and identifies the ideas that can help to solve this problem. So that's called ideation. Then next is prototype. Prototype is, okay, you all agree for one solution that you think might work. You pick that solution. You don't generalize it to every department, but you try it. It's more like, pilot study kind of a thing. And once that works, that prototype is ready, that format is ready, you do a testing of it. And if that works, then you kind of generalize it or maybe refine it further and you take it forward. Some of the examples of concept design thinking that I can share with you is like Amazon. So somebody who is running the show thought, what all my customer needs, what facilities they need. Okay, that means they want to see the variety. They want to compare the cost. They want to see what are the options. They want to know the reviews of people. They want to have the best quality. They want to have it at doorstep. They want also the facility to return back. They also want online payment option. Some of them also want COD. Some of them want to return it within 24 hours. Whatever my customer needs, can I provide them? These are the, common, services you will see. They are basically working on the concept of design thinking. Similarly, Uber, somebody who thought of Uber that, okay, there are people who don't want to drive. There are people who don't have car. There are people who like to, share their car. There are people who like to have a cab on daily basis or sometime. So Uber designed their services to meet their clientele's requirement. VFast, where we thought, okay, I want something to be moved to, given to be sent to somebody. I don't want to go myself. I don't want to wait for it to go through post or through speed post or through any other mechanism, but it should go immediately as early as possible. So there came the service called VFast. Oyo Room again was conceptualized by somebody who thought that, okay, somebody is not wanting to pay a very heavy price for the hotel, or they want to look at the options available. They want to see what are the regular charges that are, the possible options. So somebody thought of Oyo. And then Zomato. Again, there are resources available in terms of food facilities available. There are people who want to have it. So Zomato did this service providing in terms of, so all these concepts are based on design thinking. I even thought of putting IHC as one of the concept of design thinking, where I thought that we need more trainers in healthcare, people who should really come forward and take this as one of the options, career option. And then I thought we will design a program that will require the need of master trainer. So I have put my name in this. So all these are based on the concept of design thinking. You all need to start thinking in this manner. There is no ready-made solution to a problem, but Harvard says for every problem, there are minimum 4 solutions. And every solution should be tried at least 4 times before you give up. So that means there are 16 opportunities to resolve a problem before you say there is no solution to it. And I think 16 are minimum. There are many more. So we need to bring in that change in our thought process where we think patients' expectations are unrealistic. I go to the extent of saying even unrealistic expectations need to be addressed. Even if you want to say, sorry, I will not be able to do it. But we have to communicate, I'm really sorry, I wouldn't be able to do it. I can't be unhappy and, dissatisfied or frustrated with the patient. How can patients expect us to do something like this? But I would rather go and make my patient understand that I understand you expect this from me. I'm really sorry. It will not be possible for me to give you that service. So understanding patient's expectation is one of the very important primary responsibility of every healthcare provider. And let us remember, it will change. Let us not be unhappy about changing patient expectation. When the patient is going, the last expectation will be about bill, payment. Even that needs to be addressed. Even that needs to be looked after. If right from the beginning, if we have a transparent way of charging, if we have a right way of explaining that if you, like for example, I'll share my experience. My father had to undergo bypass surgery. So I admitted him in a very, primary healthcare center in Delhi. And he got his bypass surgery done. He was fine. I had to go out to visit a relative of mine for a day. I went in the morning, and while coming back, I received a phone call. It was probably second or third day of the surgery. My father was, recuperating well. So I just took the chance of going and visiting this relative. And on my way back, I received a phone call. Ma'am, your father is very aggressive. He's acting very aggressive, and we need to shift him out of the ICU. So we are shifting him to a room, but a single room, and your package will be now different. Whatever the charges were, it is now your father will be charged for the higher package. How will you justify that? How will you? Surgery is done. Patient is in ICU. It is day 3 or day 3 or day 4. You're moving him to another, room, side room or a single room. Okay, charge me for the single room. If you think you cannot move him to the double room, which we had planned, fine, charge me for the room, but you can't completely change the package. So when you make such arbitrary, billings, patients are unhappy, and they feel dissatisfied. They feel that they have been cheated. And it was a big hospital, very well-known hospital, where I had this experience. I'm sure many of you may have experienced something like this. So understanding this thing, and we need to really, keep up, changing the way we function, understand their expectation, and accordingly upgrade our way of functioning. So this is in brief. I think I have covered the last slide. Let me see if I missed anything because I stopped this share. Give me 1 second to show me. Yeah. So these are a couple of examples of how design thinking is being now, utilized in healthcare. So you may have seen certain MRIs and CT stations for pediatric clientele, where they make a setup like this just to make the child comfortable, feel relaxed, feel good, feel, in a good place. Again, these are a couple of, waiting areas of government, of corporate hospitals for the patient and their family member. This is another example of waiting area of Apollo Cradle, based on the design thinking, where you are designing your services keeping in the mind the patient's requirement and the family's requirement, and understanding their needs. And so it's time that we understand patients' expectations and we take it seriously and we meet them midway. Any questions about it?
Can I ask a question?
Sure, please.
Dr. Indu, you spoke about design thinking. So it's more to do, what I see is with the business and maybe now when we talk of care, treatment, patient's therapeutic journey in the hospital, how do you map and how do you bring in design thinking over there? Because that's been, that was the only reason it did not, grab my attention while I saw it happening for some months.
Very interesting. Very interesting. So we use process mapping very often in quality implementation. And then we identify certain steps that are redundant and they are not adding value to the service. Also, certain obstacles that are interfering with the quality service. So one day, enter your hospital. For example, you are planning to do design thinking in the OPD. So it could be about infrastructure, it could be about services, it could be about your manpower, deployment or whatever it is. So one day enter the OPD like a patient. Just imagine yourself as a patient. Okay. Now you see as a patient, if you enter the OPD services, what all you get and what do you expect? Make a note of it. Make a note of it. So maybe go with the patient as a mute observer and keep noting down what all happens with you. What could have been done differently? What challenges did the patient experience? For example, you got your registration done, and then you realize the date and day has been put wrong, or maybe department that they have put on the OPD slip is wrong. Now you need to go back. But there is no way that you can bypass the queue and directly go to the counter and talk. I'm just giving you a theoretical example. That means there has to be some way where I don't have to waste my time standing in the queue. Can I think of a way where I can save my patients time? So I'll give you an example how the concept of design thinking was used for one of the services. It was a old age home in, I think, which country was it? So what they did, they realized that the nutritional status of the patient had gone down, and they were really worried that what is happening with them. They are being given everything, and why are they not doing well, and why is their nutritional status abnormally low? So they did the process mapping. They tried to observe their eating habit. They also went to the kitchen where it was being cooked. They also saw the people who were cooking. They also saw how it was being served. Everything they observed one by one. And in each department, they identified what could be the reason for this, not good service or not up to the mark service. And they identified number of things that could be changed. I would not go into the detail because then we'll be deviating from the topic. But if we take the same example and work like in the OPD or in the OT or lab or radiology, especially these are the areas where patient and their family members suffer a lot. Just do the process mapping and try to see where you can cut down the steps that can save time and energy of the staff, of the patient, of the family member.
Makes sense. Very good suggestion.
Very true.
This is the thing. Yes.
Pick up small things. Right. I always say pick up small things. Pick up small things. Right. And the day you will find it working, you will start looking for bigger things. Okay, this can be applied here also. This can be applied here also. So empathizing means not just empathizing, oh, I feel bad for you. Empathizing means actually experiencing. If you were made to wait for 2 hours and then at the end you were said, sorry, the doctor is not, and doctor has gone for lunch, or he had an emergency case, so he has gone. So how could have I informed my patient beforehand? And a lot of time we know that the doctor is not coming, or he will not be there for so long, or the patient is not going to be seen, lab reports will not be available. Can we proactively inform the patient and the family? The biggest grudge they have is that we do not value their time. So you could even pick up this as one of the agenda. How do I save my patient's time? OPD, radiology, lab, pharmacy, wherever. Start design thinking.
This is so nice. You're so right. Thank you so much. So good.
So I thought I have to club this with this because I knew the kind of audience I have. Had I just ended with those 2 case studies, you would have said, we do it every day. But I wanted to give you a solution.
Yes.
Talking about problems is easy. Solution is something that you have to focus on.
Recently, just a comment. I recently was listening to one webinar about just tell you, learning from the experts, best practice of high performing organizations. So there was a person from US who was telling about how to be customer obsession. Now, patient obsession. Just moved away from patient delight. It is now how you are obsessed with your patient and how you can give him best service.
Absolutely, absolutely, absolutely. I think only then you will start looking at solutions. They are right there. They're right there within your visual field. There has to be a desire to try your hands. Try your hands. I mean, we move with the idea, this can't happen. This cannot happen. So this no has to be deleted from your dictionary. There is nothing called no. I don't know, I can find out. The science says you have questions and you have answers within you. More critically, you will look at it. New neurons are formed which will connect your questions to your answers. Only thing is you have to be creative in finding solutions and try. I say try. This whole program of master trainer is a trial. It could have gone wrong. I would give my 100%. Whether it happens or not, that's his wish. That's his wish.
Very true. Thank you so much.
Thank you.
Really, thank you. Thank you so
Thank
much.
you. So very
Great.
quickly, last 5 minutes, I want to tell you. One is that tomorrow's session is postponed for the reason I'm moving to another place, so there may not be internet. Next session will be on Friday, 7 to 9. And then we'll decide the time accordingly. That is one thing. Second is, please go to the pedagogies. Each one of you write your name in front of the pedagogy that you want to present. The format of presentation will be, you will be giving us a demo. For example, you want to tell me about storytelling. So give an interesting story, 2-3 minutes, and excite your audience. Give an example that, okay, you could use this as a storytelling in your program. Then talk about the advantages and disadvantages, or the care that you need to take when you are going to use this as a tool of pedagogy presentation. Then the do's and don'ts. Just 10 minutes, 15 minutes, that's all. Or for example, if you want to talk about creative visualization as a tool to, to demonstrate something. So give us an example, give us a demo. Give us a demo about, just one second. Yeah. Give us a demo on how do you use creative visualization. Then what are the do's and don'ts? What you should be careful about? What are the advantages and disadvantages? Whatever information you want to give. But this time, last time I allowed my participant to prepare on their own. I realized, no, it was not what I wanted you to deliver. So this time I've decided I'll be interacting with each one of you, maybe for 5-10 minutes, just to see what you are thinking and give my input so that you give your best and everybody gets to learn from each other. Okay, that's an interesting way of, using this tool in the training program. I don't want any one of yours training to be dry presentation. Presentation has to be just 5-10 slides. That's all. That's only when you want to talk about the theoretical concept. It has to be interactive. It has to be engaging. It has to be innovative. Okay. And now this was session 5. We are left with 5 more sessions. And you are 11 of you. So maybe in one of these sessions, we will have 3 presentations. So from next session onwards, I will not be presenting for 2 hours. I will cut down my content to 1 hour. And then 1.5 hour, not 1 hour, 1.5 hour. And last 30 minutes, we will reserve for 2 presentations. And in one of the presentation, I'll keep it to 1 hour, 15 minutes, and we'll have 3 presentations. But I want an excellent presentation from all of you. That's more like your assessment. You have to please remember. Although I'm sorry to say I'm using this word assessment, but then that will bring seriousness in our the efforts that we will put in. I'm sorry, I don't mean to.
Sure. No problem.
Just to give you that, bring that seriousness that we have to learn from each other in depth. Okay, and go ahead and write your option of session 6. So for session 6, we require 2 names. For session 7, we require 2 names, or 8 or 9, whatever. Up to 10, we have to complete all. Okay. So whatever date we will decide accordingly, you will do, but start preparing for it. Don't wait for that session to happen. Let's prepare it in advance so that you're ready with it. Okay. And it's a very friendly way of learning from each other, not like any but the presentation has to be really, really good. That's what I'm expecting from all of you. Any questions about what we have discussed, or you want to say about the?
So, a small query, Dr. Indu, suppose you said that we need to prepare our presentations. So how do we connect with you in case we want to speak to you?
So my WhatsApp number is on. Actually, my regular number also I've kept on, but we can connect on WhatsApp because then it will be like easy. I will be speaking to you maybe any day. For you, I think evening will be comfortable. Between 8 and 2, I can schedule 10 minutes talk with you, maybe on WhatsApp or maybe Zoom, whatever you want me to connect with you.
Okay.
And presentation also, what is going to be your outline? Okay, I'm going to give this demo. This will be my story. I'm going to talk. This is my do's and don'ts. This is what my advantages and disadvantages, or whatever more you want. Do R&D. Go to Google search, write down. How do you use storytelling as a tool? How do you use creative visualization as a tool? I want you to do R&D. I can give you answers, but I don't want you to give me one. Find out for yourself.
Right.
That's the way I want you to develop your R&D skills also. Okay.
Correct.
So we meet next week. Next week, we are going to talk a very interesting topic, and that's one about how do you handle aggressive patient party. The patient party who is not agreeing with you. We are going to talk about that. I'm going to send you a tool on assessing your own communication style. Do it seriously. There are certain figures you'll have to note down because there will be 20 questions. After every 5 questions, you'll have to write the total of the answers in the form, and the same answer you need to note down in your notebook for your record, which we will be discussing. I request all of you to take that questionnaire beforehand and seriously. You will get to know greatly about your own communication style and what you need to work on. It's a very simple tool, but very interesting, very enlightening tool. I'll be sharing that tool with you in the next week. I'm sorry I've taken much longer, but then. So any question, anything that you wish to ask or say? Can I quickly share the feedback form?
Yes, sure.
Give me 1 second. Yeah. Why am I not? Okay, sorry. It was right there, but I was not able to locate. So I've shared the Google form with you. If you could quickly answer, please check if it's working. I will